Good morning. This is Dr. Jim Waller from Tri-State Colorectal Surgeons, and today I thought I would take the opportunity to talk with you about one of the most misunderstood subjects in medicine, and that is the topic of hemorrhoids and hemorrhoid disease. Um, you might find this interesting to know, and a lot of physicians may not like me saying this, but very few healthcare providers, whether they be physicians, nurses, nurse practitioners, nurse anesthetists, it doesn't make any difference. Most healthcare providers know very little about hemorrhoid disease. In fact, we've all been faced with the patient who comes in and says, well, they've got a hemorrhoid problem. And as colorectal surgeons, we face the issue of almost any patient who's been referred to our office having been referred with a hemorrhoid problem just because they have some kind of a complaint with their bottom. They have pain, or they have burning and itching, or they have some bleeding. And except for rare occasions, that patient has been referred to us because they have a hemorrhoid. So I want to talk a little bit about hemorrhoids, and I want to talk a little bit about the problems hemorrhoids cause and how we treat them. Um, First of all, hemorrhoids are completely normal structures. They just as your eyes and your ears and your nose are normal parts of your body, hemorrhoids are a normal part of the body. I'm going to try something I haven't done yet since I'm very new to live streaming. I'm going to use a visual aid here. So this is an illustration of the rectum and the anal canal. This being the rectum here, this part of the body that lies between the sphincter muscles. You know, the squeeze muscle down there that gives you control. That part of the body right here is called the anal canal, and the anal canal is completely normal. And what I want to show you in the anal canal is the fact that we all have hemorrhoidal tissue. Now, just to demonstrate what I was talking about earlier, the illustrator did not draw a very good representation of the anal canal. The structures in here as they are shown are generally correct, but the way that some of the structures here and the abnormalities are portrayed are not really like they are in the human body. But it will serve my purposes. So we're not going to focus on fistula, abscesses, fissures, skin tags. We're not going to focus on any of that today. We're going to just focus on the anal canal. And the anal canal consists of an internal portion, that part above this little line that you see right here. This little line we call the dentate line. And I suppose anatomists many years ago called it the dentate line because when you look at this with a little scope, or as it's being shown on this illustration, these little tags that are present look like little teeth. Now, that's my supposition as to why that's called the dentate line. That may be absolutely incorrect. But anyway, that is an important anatomic landmark mark for us, because above that line, above that dentate line, this part of the anal canal that sits within the muscles, we call that the internal anal canal. That part from the dentate line out to what we call the anal verge, which is a part most people are going to be familiar with. That's a part you can see in the mirror. That's a part that a doctor can see from the outside without using any type of special instrument. Um, that is called the external anal canal. That is a very important distinction for several reasons. One, the hemorrhoids, which they're depicting here as this swollen, vascular cushion, the hemorrhoidal tissue above the dentate line, we call internal hemorrhoids. And you maybe have heard that term before, internal hemorrhoids versus external hemorrhoids. This portion of the anal canal down here, the external anal canal, contains the external hemorrhoid tissue. Now, what's the difference? Well, there's not really a difference in terms of what the tissue represents. The hemorrhoids represent cushions of vascular tissue, both little arterioles and venules that lie just under the lining. So if you think of the inside lining of your cheek, or the skin that you have on your face, this is a single cell layer membrane but it consists of very different cells. The cells above the dentate line are derived from the cells that line the colon, the same type of cell, and the cells that line the anal canal are more like your skin cells. In fact, they're called a squamous epithelium, just like your skin cells. But unlike your skin cells, which are many layers deep or many cells deep, this is a single cell layer that lines the external anal canal. So that the hemorrhoid tissue above the dentate line we call the internal hemorrhoid tissue, and the tissue below the dentate line we call the external hemorrhoid tissue. And under normal circumstances, the anal canal is going to look like we see in this representation over here. We know that vascular tissue is present under the lining, but under normal circumstances, it's not enlarged. It's not protruding. It's not uncomfortable. It's not causing any bleeding. So that's the difference between internal and external anal canals. And I think even before I was in medicine, I had heard that distinction before. What's interesting is that a lot of healthcare providers don't understand the difference in the hemorrhoidal tissue, and as a result, they don't understand the pathophysiology of the hemorrhoid tissue when a person has a problem. So hemorrhoids are normal structures. Most of us have three of them, and I'm going to put this down for a moment. Because with patients, I always like to use my hand as an example. So if I have a patient lying on the table on their left side, which is how we do this, this would be the front, this would be the back, your tailbone would be back here, this would be your right, this would be your left. And I always found the folds of my skin to kind of be a perfect way to show patients the anatomy of their anal canal, because we have a column of hemorrhoid tissue on the right side toward the front, on the right side toward the back, and right in the middle on the left. Again, under normal circumstances, we don't see any prominence of the hemorrhoid tissue. That column of vascular tissue extends from right here on the anal verge, as I showed you on the illustration, up in the inside a short distance, maybe just 3-4 centimeters in length. So the anal canal is relatively short. One of the big differences between an internal and external hemorrhoid is the fact that the internal hemorrhoid, because it's lying under the lining of the internal anal canal, has very little, if any, sensitivity to pain. And any of you who've had colonoscopies, you may note that if you've had a biopsy or you've had a polyp removed during the procedure, you don't have pain afterwards, because the inside lining of most of the intestinal tract does not have any sensitivity to pain, at least that type of pain that would be caused by doing a biopsy or removing a polyp. So the internal hemorrhoidal tissue is relatively insensitive to pain. This area of the anal canal, for any of you who've ever had any trouble, that includes me, because it's been estimated that 80% of us at some point or another in our lives are going to have an issue with our hemorrhoids, whether that be bleeding, some type of protrusion, or pain. But anybody who's had an issue down here with a thrombosed external hemorrhoid may have had rather significant pain, or if you've had a fissure, or if you've had an abscess or fistula. This is a very sensitive area of the body, much like your feet, your head and neck area, your hands. This is a very sensitive part of the body. So, important distinction between an internal and external hemorrhoid. So we all have three. There's a column on the right side toward the front, right side toward the back, right in the middle on the left. Under normal circumstances, they do not cause any symptoms. Now, because of the location of the hemorrhoid tissue and the fact that the external anal canal is sensitive and the internal anal canal is not, we get very different symptoms when we have a problem with the hemorrhoid tissue. And I'm going to go into those a little bit. With internal hemorrhoids, the most common problems we will see, if a patient indeed is having some problems, is painless bleeding and or painless protrusion. So that's probably that may be the most common problem we see with hemorrhoids. In fact, as I mentioned before, 80% of us will occasionally have an issue with hemorrhoids, and it's not uncommon at all for a patient at some point in their lives to have some painless bleeding. And it's something that can come or go. It's not serious. And again, it's not painful. Now, along with bleeding, some patients will also, over time, develop some enlargement and potentially some protrusion of the internal hemorrhoid tissue. And again, going back to my diagram, that is represented by showing this enlargement here in that hemorrhoid tissue, in that vascular column. Now, that's something we can see using a small scope, a small anoscope. And that's an important point, because if someone looks at a patient with, let's say, with a colonoscope, you don't really get a good visualization of the hemorrhoid tissue with a colonoscope or a proctoscope, or certainly with the naked eye, because you can't see it. It sits within the anal canal. The muscles are keeping the anal canal contracted, and it's very difficult to get a view of the anal canal without using a little side viewing scope, a little sliding scope that allows us to hold the anal canal open about the size of a bowel movement and take a look at the actual lining of the anal canal. So if someone comes in with painless bleeding, some painless protrusion, we're going to do an external exam. We're just going to look. We're probably going to check with a finger, again, no bigger than a bowel movement. And we're going to look with a little scope to look at the anal canal and to assess it. So the most common problem that we will see being caused by an internal hemorrhoid would be some painless bleeding or painless protrusion. Now, if that's occurring, how do you treat that? Well, first of all, except in younger patients, where we're fairly certain that because we see an abnormality, we may not do any more of an examination. In fact, as colorectal surgeons, we've kind of come to the conclusion that in younger patients, intermittent bright red rectal bleeding, where you see some obvious source of the bleeding, that we don't do extensive examinations in those people. We've gone through phases where we've recommended, well, do a colonoscopy or do a more extensive exam before you blame it on the hemorrhoid. And that's certainly true in older patients. So if you're over the age of 35 or 40 and you have bleeding, we may or may not do a colonoscopy. And certainly as you approach the age of 45 or 50, if you're having some bleeding, we're going to do a colonoscopy to be absolutely certain that the bleeding is not coming from higher within the colon. Now, that said, even in patients who come in, they've had some bleeding, we do a colonoscopy and we find a polyp or cancer up higher in the colon. Even in those patients, most commonly, the blood that we were seeing was not coming from the cancer we found. It was coming from the anal canal. It may have been the thing that got us to look through the rest of the colon, but in almost all cases, that blood was coming from the anal canal. The exception being if a person has a very low-lying polyp or low-lying cancer. So, most common cause of painless rectal bleeding is and by that I mean blood coming out of the rectum, is bleeding from the anal canal secondary to internal hemorrhoids. Now, the internal hemorrhoid quite often is not enlarged at all, or if it is becoming enlarged because that tissue within the internal anal canal is soft and pliable, and you've got this vascular tissue sitting just under the lining, quite often that tissue will become enlarged just with straining and normal bowel movements and just a lot of times the gravity, a lot of times hereditary. People who have problems with their internal or external hemorrhoids, if you talk with them, quite often they've had family members who have had issues. So anyway, seeing issues with the internal hemorrhoids is not uncommon, and it's a very common, in fact, I would say, as I said before, the most common cause of painless bright red rectal bleeding in patients across the board. So what do we do about that? Well, we'll do an examination, as I mentioned, which may sometimes include a more extensive exam of the colon, a colonoscopy. And if we're comfortable that the bleeding is coming from the internal hemorrhoids, one option is no treatment. It's very, very rare for people to get anemic from that type of bleeding. Okay, so even if we can't get it to subside completely, one option is no treatment. But generally speaking, we take a stepwise approach. I mean, it's a logical approach based on outcome-based data. And what we will do is we will have them bulk up their stools by getting more fiber in their diet, possibly adding some supplemental fiber such as psyllium, which is found in Metamucil and many of the over-the-counter fiber supplements or psyllium, but there are other supplements as well. But we'll just add fiber supplements. And we found that probably half the patients who come in with symptomatic internal hemorrhoids will see improvement or complete alleviation of their symptoms simply by increasing the bulk in their diet. We sometimes will recommend a topical cream that is placed within the anal canal. And then we do that by most of these creams come with a little applicator and with little holes in it. And many of you may have done this before. You simply put that in the anal canal, squeeze a little bit of the ointment out, and pull it out, and it coats the anal canal. I've always been, and I think a lot of physicians are skeptical about how much good that does. There's nothing magic in any of those formulas. I think if anything else, they probably just provide some lubrication of the anal canal, which may help to alleviate the symptoms. So that's going to be our first line of therapy, because we know that at least half the patients are going to improve just doing simple stuff, dietary changes, addition of fiber, and possibly using some ointment. Now, if a patient continues to have bleeding, or let's say that they have significant enlargement of an internal hemorrhoid, again, going back to our diagram as they're showing here, such that it looks like this, or may in fact be protruding to the outside, not like this. We're not talking about an external hemorrhoid yet, but these can protrude to the outside. And in fact, they can get to the point where they may begin as symptomatic hemorrhoids, where a person is noticing a little bit of protrusion when they go to the bathroom, which goes back on its own. They may get where they have protrusion that they have to actually push back in, or they may get to the point where the tissues it's protruding and it's sitting on the outside all the time. That becomes a little bit more of an issue, because I think in most cases that's less likely to stop bleeding by itself. And particularly if they're having significant protrusion either into or completely through the anal canal, it's not likely to subside very much unless they had some kind of an acute event where there was they were straining real hard or something that caused them to enlarge, acutely. Most of the time, it's not going to go down. But long and short of it is if we have a patient who's having continued symptoms of bleeding, or bleeding and protrusion, or just simply protrusion, we do have options to treat this and treat it without discomfort and without conventional surgery. And when I say without discomfort, most patients, if we treat those internal hemorrhoids, they may get a little pressure sensation for a few hours to a day or so, but they're not having a regular hemorrhoid surgery. And most patients, when we treat the internal hemorrhoids, they can resume normal activities right away, or certainly within a day or so, once any pressure they have down there subsides. There are several different ways we can treat the internal hemorrhoids, and I will go back to something that Dr. Pat Mazier, who was the director of my colorectal program, taught us the first few days we were there, because obviously when you go into colorectal, they make you very aware of the things I'm telling you about today with regard to hemorrhoids and hemorrhoid problems, and that is, all that hurts or bleeds down there is not a hemorrhoid, and treatment of hemorrhoids is strictly elective. That being said, another thing that Dr. Mazier told all of us is if you can reduce the vascularity, reduce the size of the internal hemorrhoids, the symptoms are going to get better. So that in mind, probably the most common thing that we do today to treat internal hemorrhoids is we do something called ligation. And ligation consists of putting a rubber band, using a little applicator that we have, putting a rubber band around the base of that internal hemorrhoid. That ties it off, and that tissue will then slough off after a period of a few days. And having done this for many years, at different times, I had the opportunity to check a patient even 7 or 8 days after they had had a procedure done. And quite often that band is still there. We always tell people in 3 or 4 days it probably sloughs off and the tissue sloughs off, but in fact, sometimes it may stay on there a little bit longer. So that if we have a person who is having significant protrusion and having bleeding, and it doesn't respond to our usual measures, that is an option. And that's probably the most common thing that is done, I would say, around the country. That's the most common thing myself and my partners have always done. It's very effective. It's safe. It's simple, and very little discomfort associated with that. Now, we have the situation sometimes where a person is continuing to get bleeding. They're bothered by the bleeding, even though the hemorrhoid tissue is not significantly enlarged. What do you do about that? Well, if it doesn't respond to our conservative therapy, the other thing we can do is we can use an infrared coagulator, where we actually use infrared light. So unlike putting a band on that hemorrhoid, putting a band around that hemorrhoid and choking it off, we use infrared to coagulate the blood vessels beneath the lining of the internal anal canal. And that's very effective also at preventing bleeding. There are a number of other techniques that have been developed over the years. Um, uh, I always found some of them to be a little more complicated than they need to be. And in our specialty of medicine, just like other specialties of medicine, the equipment manufacturers are always coming up with some type of new device designed to do the same thing to obliterate those blood vessels, but usually at a much higher cost for the equipment and to do the procedure. Um, I'm kind of a keep it simple kind of person, and you just can't beat ligation for its simplicity, the fact it can be done in the office without any sedation, and its results. So that's how we approach the treatment of internal hemorrhoids. External hemorrhoids are a completely different animal because, again, they lie in this part of the anal canal, the external anal canal, and much like this illustration shows you, right at the very opening. And this part of the anal canal is really sensitive. And any of you who've had any problems down there, I know are aware of that. Again, I'll use myself as an example. I've had several small thrombosed external hemorrhoids. So that's the only time a hemorrhoid hurts, is when you have a thrombosed external hemorrhoid. And that is an important concept. Okay. Just having a skin tag down there, as this is showing right here. Okay. Um, that's not a hemorrhoid, and that's generally not painful. Lots of people develop skin tags. Again, the skin down there is very loose. Over time, gravity, straining, people can get skin tags for a variety of reasons. People who have had an abscess, or they've had a fissure, or they've had a thrombosed hemorrhoid in the past, they can they can develop a skin tag. Skin tags are generally, they're not painful. They can cause you to have irritation and burning and itching, but they're not hemorrhoids. Okay. So the problem that external hemorrhoids cause is if they become thrombosed, they lie in a part of the anal canal that's very sensitive to pain. And as a result of that, you're going to get a swelling, again, as this shows, because what has happened is some of those blood vessels within that hemorrhoid column have ruptured and it's become thrombosed. And so you got a blood clot down there. It's not a blood clot that is dangerous. It's not a blood clot that's going to go to your brain, like a big blood clot in one of your pelvic veins, or in your upper thigh veins. It's not dangerous like that. It's just, it causes a lot of pain, because when a person gets a thrombosed hemorrhoid, they tend to get a lot of inflammation in the surrounding tissue. So a thrombosed hemorrhoid is painful. It's the only time that's the only time a hemorrhoid causes any significant pain. But again, something to remember about hemorrhoids, again, Dr. Mazier taught all of us when we started the program, they'll always get better on their own. So one option for treating external hemorrhoids is leave them alone. Now, I can tell you, in all the years I was in practice, patients are so accustomed to seeing things on TV or hearing other healthcare providers make reference to hemorrhoids, or talk about draining hemorrhoids as if they're an abscess. Abscess is a different animal. Abscess needs to be drained. Abscesses feel better immediately after you drain them. A thrombosed hemorrhoid doesn't act that way. For whatever reason, and doctors have tried this for years, if you cut that hemorrhoid open and you pop the clot out, the patient still has a significant amount of inflammation. They have a wound, and they still have discomfort for a week or so. In fact, one of the things that I have always told patients is that when they come in with a thrombosed hemorrhoid, I will say, okay, we can remove this. And by remove it, I mean, you don't just make a little incision and pop the clot out, because quite often that recurs, but you actually excise that, you unroof it, and you excise some of the blood vessels under the skin, to treat the thrombosed external hemorrhoid. But again, they'll all get better on their own. Even if a person comes in and all three hemorrhoids are thrombosed, because we'll see that sometimes. All three will be thrombosed. There will be a big rosette of thrombotic, inflamed, ugly looking tissue down there that looks gangrenous, and it's not. And if you just give that time, the body will resorb that clot. Sometimes it'll kind of, your skin will ulcerate a little bit, and some of it will come out on its own, but that will go down over time. And what we have found is that usually in 3 to 7 to 10 days, the pain's gone. Swelling won't be gone yet, but the pain is gone. So one of the ways to treat thrombosed external hemorrhoids, and what I have done in my own case, where I've just had 2 or 3 episodes where I had small ones and the pain was not severe, stand in the hot shower, sit in a hot tub, do something called a sitz bath. You can put topical ointment on them. I will point out that all the topical ointments are equally ineffective when it comes to treating external hemorrhoids. The ointments don't promote the shrinkage and drainage of hemorrhoids. I've seen that on commercials. They don't do that. I have always had people use some type of topical ointment as a lubricant, because if you've got protrusion, and you're trying to walk or sit, you're going to get irritation from just the cheeks of your buttock rubbing back and forth, and so they can get tender as a result of that. So I have always had people use a topical ointment, but I've cautioned them, hey, this is no magic potion, and they're not going to get better right away. It's going to take 5 to 7 days, or maybe longer, but you're going to see gradual subsidence of the pain. You may get some bleeding. That's normal with this as well. But just tincture time is going to allow these to get better. And so I think most of us, when we see a patient, if the patient comes to see us and it's been more than 48 hours since the onset of their symptoms, we're going to try and get them to allow these to go down on their own. Now, we typically will send patients home with some pain medicine. In my case, in the latter years of my practice, I never used any narcotics. I would send them home with a non-steroidal, Aleve, ibuprofen, prescription doses, obviously. Or my favorite was always something called ketorolac, which is Toradol, and it is an excellent pain medicine. In fact, it's more effective than opioids in actually taking care of the pain, and that would get patients through until they started getting some absorption of that clot and reduction of the swelling and improvement in their pain. And so that's how I treated the majority of patients. In fact, one of my partners and I, Dr. Dean Smith, we always kidded about the fact that we did fewer hemorrhoid surgeries than most general surgeons. And that may seem peculiar, but if you think about it, it's because of what we know about the natural history of thrombosed external hemorrhoids. They'll always get better on their own. If you can get patients through those first few days, they're going to feel better, and you're going to save them a surgery. Because I can tell you, hemorrhoid surgery is very painful. Now, patients that we would do a hemorrhoidectomy on are those patients who they just absolutely wanted to have something done. They didn't want this to ever happen to them again. And so in those patients, we would sometimes go ahead and do a hemorrhoidectomy. Other patients that we would offer a hemorrhoidectomy to would be those patients who'd been in with recurrent episodes. I mentioned I've had 2 or 3 of these in my life. Again, 80% of us are going to have some issues with hemorrhoids. That could be just bleeding from internal hemorrhoids or thrombosed external hemorrhoids. So it's not uncommon for someone to have a problem, but there are those people where they begin to have recurrent problems. So if they're having thrombosed hemorrhoids, if they've had multiple episodes in their life, if it's happening to them 2 or 3 times a year, it might behoove those people to consider undergoing a hemorrhoidectomy. As I said, hemorrhoidectomies are painful. We're going in there and we're going into the anal canal. And when we do a hemorrhoidectomy, because that is a continuous column of blood vessels, as I described earlier, we make an incision that starts up here so that we can remove that entire hemorrhoid, both the internal portion and the external portion, because those blood vessels are interconnected. So we take out the entire hemorrhoid column. Well, the part of the incision we make up here, as you may have already guessed, that part of the incision, that's not uncomfortable. That's where the major blood supply is coming in, but that part's not uncomfortable. The uncomfortable part is that incision that we have made right here in the anal canal and out on the perianal skin. And as we've already talked about, that part of the anal canal is very sensitive to pain, and it's going to take several weeks for those wounds to heal. Now, as with any other surgery, you get most of your pain in the first week or so. But I always just told people, you may be hurting for 3 to 4 weeks, and so I always had that discussion with patients before they made the decision to have a hemorrhoidectomy. And in virtually all the patients I took care of, I let the patient make the decision. I told them what we know about the natural history of external hemorrhoids, and I talked with them about the efficacy of doing a hemorrhoidectomy, and the amount of discomfort they were going to have in the post-op period. Hemorrhoidectomy surgery is very effective. Only about 2% of patients who have a hemorrhoidectomy are going to have a recurrent hemorrhoid, but we don't, I should say, a recurrent thrombosed external hemorrhoid, but we don't remove all the vascular tissue from the anal canal. We take out those three main hemorrhoidal columns. There are still blood vessels down there. And I can tell you, having done this long enough, you will see patients come in and they'll be most upset that they had another thrombosed hemorrhoid after having a hemorrhoid surgery some years ago. I can tell you that if it was my patient, I had already warned them this can happen. It's only about a 2% chance, but it can happen because worst thing we can do as healthcare providers is not be completely honest and upfront with people. Because then when you have that rare complication, they're most upset with you because they were under the impression that, well, there's a 100% chance this isn't going to happen again. So I'm been kind of a rambling discussion, but I hope that people now understand the difference between internal and external hemorrhoids and the kind of problems that internal and external hemorrhoids cause. They generally don't cause burning and itching. They generally, if you get, and I will have some further discussions in the future about anal fissures, which is probably the most common cause of pain with bleeding that we see in the office. It's not a hemorrhoid, it's a fissure. We see pruritus ani, which is another common problem, especially in our society today, probably related to diet and cleanliness and a number of things. But that's chronic burning and itching. And pruritus gets misdiagnosed as hemorrhoids often, uh, as do fissures, as do skin tags. So I hope that this helps people understand that hemorrhoids are benign, normal structures in the body, that they can cause issues with internal hemorrhoids causing painless bleeding or protrusion, and external hemorrhoids causing problems when they become thrombosed and being a cause of pain. The other thing that I would suggest to patients is that if you have an anorectal problem, um, unless it's life-threatening, I would not present to the emergency room. They're way too busy taking care, particularly in this time of COVID, taking care of patients who have more serious issues going on. And there's very little they're going to be able to do there. And a lot of the providers are not as familiar with anorectal anatomy as, say, a gastroenterologist or a colorectal surgeon would be. And that, in fact, is why we offer a walk-in clinic here for people who have acute pain and feel like they need some immediate help. Be aware of the fact that a lot of urgent care centers, emergency rooms are probably not the appropriate place for that because they're dealing with a lot of different issues and have not been specifically trained in the anatomy and diseases of the anorectal area. So with that, I say thank you for listening to this rather long diatribe on hemorrhoids. I hope it's been helpful and feel free to submit questions. Thank you. Goodbye.